Hello, thank you for joining our webinar with Dr. Lauren Siff, a VCU Health urogynecologist. Today, Dr. Siff will discuss an issue that affects women of all ages. It can seem embarrassing, but this condition is more common than you think. We are talking about bladder leakage today, also known as urinary incontinence. Dr. Siff will discuss the different types of urinary incontinence and what you can do about it. So if it bothers you, know you no longer have to just live with it. My name is Debbie Schumacher, and I'm a member of VCU Health's marketing team. Before we begin the presentation, I just wanted to let you know that we will be answering questions, and please put them in the comment section, and we will answer them at the end of the presentation. Let me tell you a little bit about Dr. Siff. Dr. Lauren Siff is a board-certified OBGYN who completed her subspecialty training in female pelvic medicine and reconstructive surgery at the Cleveland Clinic. She specializes in pelvic health problems, including trouble with bladder and bowel control and pelvic floor prolapse. Dr. Siff and the multidisciplinary pelvic health team at VCU Health offer an array of therapies to treat these sensitive female conditions, including physical therapy, devices, medicines, and minimally invasive surgeries. Thank you, Dr. Siff, for joining us today.
Thank you, Debbie, and thank you for introducing me. I look forward to giving this presentation and to our discussion at the end.
Me too. I'm going to turn it over to you now.
Perfect. All right. So I'm here to talk to you about urinary incontinence or urine leakage. I'm going to tell you a little bit about myself, as a lot of people have questions of what is FPMRS. This is sometimes you'll hear that you're going to see a surgeon, a female pelvic medicine and reconstructive surgeon. You may also hear the terms urogynecology or female urology. All of this talks about what I do. It's a board certified specialty, and either you can start as an OBGYN or urologist. I came at this from OBGYN. What is my scope of practice? I see and treat people with pelvic floor disorders, and we'll go into what that means in just a minute. I perform bladder and bowel tests in the office to help diagnose what's actually going on with you. And then I help make an individual plan for you based on your goals and what your treatment would be. The other thing that we do as urogynecologists is really to promote pelvic health through research and education. My areas of expertise can fall really in three main buckets. This is the bladder, the vagina, or the bowel. So I focus in terms of bowel on urine leakage, sometimes on difficulty emptying your bladder, recurrent infections. Vaginal symptoms could include pelvic organ prolapse, a dropped bladder, a dropped uterus. Bowel could include accidental bowel leakage or fecal incontinence and difficulty with your bowels. I work with a multidisciplinary team, which means we have a large group, a variety of specialists: gynecologists, urologists, GI or gastroenterology, colorectal surgeons, and pelvic floor physical therapists. We work together in the office on a daily basis, and we meet as a board group once a month to go over complex patients and patient problems that we put our heads together to find a solution for you. So what really is the pelvic floor? It's this set of muscles and connective tissue that really support both the organs themselves, and you can see here the the bladder, vagina and uterus, and the rectum, and also help support their function as well. One of my favorite coffee cups given by a patient: may your coffee, pelvic floor, intuition, and self-appreciation be strong. So what are pelvic floor problems or pelvic floor disorders? This woman's got a number of them. If my body were a car, I'd trade it in on a newer model. Every time I cough, sneeze, or sputter, my radiator leaks and my exhaust backfires. You may have a number of these. And as we said at the beginning, this is really common. As a woman, your chance of getting a pelvic floor disorder, what do you think? 1 in 3, 1 in 8, 1 in 15. If you can believe it, 1 in 3 women experience a pelvic floor disorder in their lifetimes, and up to 1 in 9 have surgery for this. And women of all ages can be affected. 1 in 4 women ages 20 to 39 years old will have these symptoms. Some of this can be from weight pressing on the pelvic floor from pregnancy or being overweight. Bodybuilding or intensive weight training is also a risk for this. With age comes skills. It's called multitasking. I can laugh, cough, sneeze, and pee all at the same time. Another one of my favorite cartoons. But it's true. Urinary incontinence does increase with age, and up to almost 40% of women over aged 80 have urine leakage. So in terms of urinary incontinence or urine leakage, this comes with a variety of symptoms. It can be leaking with laughing, coughing, sneezing, lifting, exercise. You might just have gotta go feelings. Some people wake up wetting the bed at night. Others have a slow stream or feel they're not able to empty their bladder. And some people, it leads to sexual problems where they have urinary urgency or leak urine with sexual activity. My job is to really sort out your symptoms and try to put them into one of the 3 main types of urine leakage. Stress incontinence is that urine leakage with coughing, laughing, lifting, exercise, some stress on the bladder. And these are usually, as you see here, kind of small volume leaks. Urge incontinence, on the other hand, or some people discuss an overactive bladder. This is that gotta go, up all day, up all night, kind of leaking on the way to the bathroom. Some people say, you know, as soon as I get the key in the door, as soon as I hit my feet on the floor in the morning, or when I pull the car into the garage, I'm leaking and I can't control it. And then there's this other type, and this can be a mixture of symptoms where you can't exactly tell what's going on. You just feel wet all the time, or just flooding, or you know you need to go and you physically just can't get there for other reasons, mobility, other, hip injury, for example. So I'm going to go through these different types and how you might treat them, and they are treated really differently, so it is important to understand the different types. The first we'll talk about is stress incontinence. So this is kind of a pull and tug back and forth of the urethra and the bladder. So the bladder will have a stress on it, a laugh, a cough, a sneeze, and the urethra bounces around and leaks. So what we need to do is find, it has to do with kind of the pelvic floor support underneath the urethra. So risk factors for this are things that decrease the strength or the support of the urethra. That's childbirth, aging or menopause, or prior pelvic floor surgeries. It can also be kind of anything that increases the pressure on the bladder. So whether you're carrying more weight, how you have COPD or chronic coughing, chronic constipation, those sorts of things. The way that we work this up is really to find out, 1, we make sure you don't have a urinary tract infection. 2, we make sure that you do in fact empty your bladder. So we check how much is left. And here you can see someone checking with a bladder scan or ultrasound. This could also be done with a small catheter. We also have you cough and look for leakage on exam. And we do have more formal and more complicated bladder testing if your problems are a little bit more complicated. The treatment options then range from pelvic floor exercises. Here you see on the right, our patient here, always one for keeping fit. Susie did her pelvic floor exercises, squeezing a bottle of wine. We also have non-surgical options. And I'll show you some of these examples. We have procedures that we do in the office, and we have surgery. Again, all aimed at either strengthening the pelvic floor or supporting it. So some of the devices, and you can see kind of in this far right one here, you want to support the urethra from underneath, from the vaginal side of things. So there are tampons that can do this. You can use a regular tampon, or you can get these tampons that are shaped like a pyramid that give you that support underneath the urethra. Also, we have pessaries, or you can see these silicone rings here, and they have a knob that supports underneath the urethra to, when you laugh and cough and sneeze, give you that backstop that you're missing. We also have bulking procedures. It takes a urethra that's kind of wide open like this. We inject through a camera into the bladder and the urethra on each side a small pearl of bulking agent that takes the urethra from this to narrow like this. These are really great, particularly if you're wanting to avoid surgery in the operating room, but you need a little bit more than those other therapies. We also have surgery, certainly. These are our sling procedures. These are made of an FDA-approved safe mesh material. They look like a ribbon, as you can see here, two kind of different ways you can place them. They are lightweight, about the width of my pinky and flat like a piece of paper. And right there you can kind of see the up close of what that material looks like. And those, as you see, sit in, here's the two pelvises. They sit underneath the urethra and give you that support you're missing. That's placed in the operating room. It's about a 30-minute procedure. You go home the same day after that. They certainly do have complications, as they are a surgery. So some of those could include, injury to the bladder, or some of the material, even though it is FDA approved safe mesh material, there is about a 2% chance it could grow through the tissues. And so we would, if you've had a sling before and come to me with these symptoms, I certainly take a look in the bladder with a camera and do more formal testing to find out if these have had any issues for you. There are also treatments, which are surgeries not using mesh material, and there are a variety of reasons patients would prefer to have one of these. Sometimes we harvest your own tissue to create a sling, and other times we place stitches next to the urethra and attach them up to the pubic bone to give you that support. On the other hand, that's all our stress incontinence, that leakage with laughing, coughing, sneezing activity, and wanting to really support or strengthen the tissue around the urethra. On the other hand is overactive bladder or urge incontinence. This is that urgency, frequency, up all day, up all night, and leaking on the way type of symptoms. You see, I called the incontinence hotline and they asked, "Can you hold, please?" This is the, patients who say, "I just cannot hold my bladder. I get the urge, and before I can even get to the bathroom and get my pants down, I'm already leaking." And sometimes it's just urgency, frequency, and there is no leakage. And we kind of lump all of this into overactive bladder syndrome, which is a constellation of symptoms or a number of symptoms because they can be treated similarly. This has to do more with the nerves to the bladder, and so we'll focus our workup and treatment on that. The exam is similar to stress incontinence, where we want to make sure you don't have a urinary tract infection or UTI. We want to make sure you do empty the bladder all of the way. And we want to look for any leakage, but now we're also sometimes focusing on a neurologic exam, testing reflexes at times, taking your history for those types of problems. We also look for thinning of the vagina, which can lead to very irritative bladder symptoms as well. We'll often do a rectal exam because constipation can really affect the way you empty your bladder and can lead to this type of incontinence as well. And we also check other medical causes. Our treatment options here is a similar approach. This is a stepwise therapy. In this case, really 3 steps. The first is some more conservative things, behavioral modifications, and I'll tell you about those. The next is medical, so medications, and then we have procedures. I love the Golden Girls. This one says, "I go in the morning, every morning like clockwork. At 7 a.m., I pee. Unfortunately, I don't wake up till 8. And that's a lot of people can tell you that story. So some of the conservative treatments that I'm explaining to you, some of this is weight loss. We know that the more weight you carry, the worse your incontinence can be. We also talk about avoiding bladder irritants. These are classic, we know things that classically irritate the bladder. This is caffeine, alcohol, spicy foods, carbonation, citrus. We also, again, look at a bowel regimen, again, making sure you don't have constipation. Physical therapy can be helpful too. A lot of this is aimed at managing your fluids and your voiding at the same time. So for example, we want your voiding to be consistent throughout the day, like every 2 hours. You're setting a timer and going to urinate throughout the day. Don't wake yourself up at night to do that, please. We're also managing your fluids similarly, where you drink like 4 or 5 ounces an hour. So you're kind of keeping this slow sipping consistently throughout the day, rather than what a lot of people do, which is a ton in the morning, nothing all day, and then a ton in the evening. Trying to avoid those shocks to the bladder and train it to listen to you. The second lineup would be medications, and there's really kind of 3 classes of medicines. Antimuscarinics or anticholinergics. These are all of they're all really similar. You probably see a lot of them on the commercials. Detrol, Ditropane, Vesicare, Toviaz, you name it. There's a ton of them. You can't have these if you've got glaucoma, gastroparesis, or you don't empty your bladder. It's important to choose an extended release or a patch version of these because it helps you avoid some unwanted side effects like constipation, dry eyes, dry mouth. We do have to be careful of cognitive effects or confusion. They do have an increased risk of dementia, particularly after age 65. So we're very careful with that in many patients. The next is mirabegron is the only medication in its class. And the reason you couldn't take that is if you have uncontrolled high blood pressure. And certainly vaginal estrogen cream. This is you just put a little pea size on your fingertip and put it right at the opening of the urethra and vagina every night. It helps with thinning of the vagina and a lot of times with these urgency frequency symptoms and helps prevent urinary tract infections. So it can be quite helpful and really a medication that you don't have to take in pill form. There's also surgeries for overactive bladder, urge incontinence, or procedures. So here you see this foot here has got a little tiny needle, like an acupuncture style therapy that's attached to a stimulator device. You come in weekly for 30-minute sessions of stimulation for 12 weeks. And then after that, we kind of see what kind of maintenance therapy you would need. And this is done in the office. And then we also have Botox injections to the bladder and a bladder pacemaker. The Botox injections I typically do in the office. You take a look in the bladder with a camera and identify small locations and inject a little bit of Botox, kind of relax the bladder so that it's not constantly squeezing. And then here in the kind of flanking pictures, you can see we place a needle in the kind of through the back to the nerves to the bowel and the bladder and attach this to a pacemaker that can also help with urinary urgency, urge incontinence. It can actually help with people who hold in urine and also help with leakage of bowel. So it can be a good option as well. That's done in the operating room. Again, just to kind of remind us that for stress incontinence, really you have all the options to you from the get-go. All of those are effective and you could choose whichever you want. For overactive bladder urge incontinence, we do kind of follow a 3-step process. The first here you see this evaluation and then the conservative therapies first. Medications would be next. And then if those are really not working, we're starting to look at those, what we call 3rd-line therapy or those procedures. So I know I've given you a lot of information. Certainly we would individualize that to your own symptoms. And sometimes you just can't tell. So if you have any further questions you want to know about your personal issue, please give us a call. We can make an appointment and spend some more time getting to know what affects you and how we can help you. And you can also go to the link that we'll add here to download a free guide and get a little bit more information as well. And I'm happy to take any questions from the audience at this point.
Wow, that was amazing, Dr. Siff. Very, very informative. I learned a lot and I'm ready to make an appointment. I learned a lot about the various types of bladder leakage and what you can do about it. So just to repeat that, if you want to make an appointment with Dr. Siff or her team, please call 804-628-0691. And if you want to learn more, there is a link, as she mentioned, to download a guide, and you can find that link in the comment section. We'll now open the floor to questions. There were some questions that came in advance, so we'll go through some of those and then we'll address the ones in the comment section. So let's start. First question, who is exactly at risk for developing pelvic floor conditions?
This is a great question. We think some of the common risk factors can be women who've had vaginal deliveries, things that could make it even a more increased risk if you had long labor, very large babies, lots of babies. But even women who've had C-sections, just pregnancy alone can kind of put that pressure on the pelvic floor and increase your risk. Other things would be menopause or thinning of the vagina that goes along with menopause that can contribute to these symptoms. And often people who've had pelvic floor surgery, hysterectomies, slings, other things, even other pelvic floor surgeries unrelated to these conditions can lead to this. And sometimes it's just your connective tissue, your genetics, or bad luck.
A little bit of everything. Here's another question about the pregnancy. I've actually heard pregnancy can lead to some leakage, which you did mention. If you have multiple pregnancies, does that leave a lasting problem with bladder leakage?
That's a great question. We do think that you are at increased risk after pregnancy, but we will see that some women's kind of bladder function does go back to the way it was pre-pregnancy. And we do get a lot of information in those first few months, kind of that 6 to 12 month period after having a baby of what this might be like. You may also then go a number of years with no symptoms and later have other risk factors that could lead to it. So we can't say exactly, but certainly just because you had many babies doesn't mean that you're kind of doomed to a life of bladder problems. So don't worry about that.
That's good to know. Here's another one. You talk a lot about that you can do exercises and some physical therapy. Could you give some examples of what some of those exercises might be to help treat?
Absolutely. A lot of people have heard of Kegel type exercises, and these are kind of squeezing and holding. We kind of describe it as squeezing in like you're trying to hold in your urine. Those are the muscles you want to focus on, but definitely don't do that on the toilet. I tell people it's nice to do that about twice a day, kind of maybe even 20 squeezes if you can. Tell people maybe as you're going to sleep at night or as you're snoozing the alarm in the morning, those are two things you're going to do every day. And so that's kind of sometimes you can remember. I've actually done some other studies myself on commonly performed exercises that can help the pelvic floor. And some of these are actually core exercises and some yoga type positions and Pilates type exercises that can be helpful as well. And certainly you could do those on your own. And we have some wonderful physical therapists here at VCU in all our locations, but definitely in my office at Stony Point that work with patients on a daily basis. Because sometimes you just can't tell. You feel like you've been doing these exercises. You just can't tell if you're doing it right. So it's nice to have a consultation and someone to kind of confirm that or maybe coach you through that, at least in the beginning.
You did touch on this, but does bladder leakage get worse as you get older?
It can, because I think as you age, you do stack up more of the risk factors. Menopause, often hysterectomy or other surgeries. Some people have other medical conditions also with age. So let's say you get really swollen legs at the end of the day. Some people will then say, well, I go to bed at night and I'm up all night leaking. Well, really you're raising your legs up and putting all of that fluid back in. So there could be some medical conditions associated with age in addition, but we do know that as you age, you do see an increase. I mean, I'm pretty shocked, and I think it's an underestimate about 40% of women at age 80 and above that have bladder leakage. And those are women seeking care for it. So there are many more.
Yeah. Bet they're keeping depends in business too.
Right?
But they need to see you.
Yeah, exactly. Exactly.
Is bladder leakage more common after a hysterectomy?
You know, not everyone that has a hysterectomy does have bladder leakage, but you can sometimes see an increased risk of leakage, either type actually. Stress incontinence can be if you have disruption of the pelvic floor support from having a hysterectomy. So certainly that may lead to some leakage with coughing, laughing, sneezing. Also, a hysterectomy, depending on the reason you had the hysterectomy, may affect the nerve and how kind of extensive it was, may affect the nerves to the bladder and can contribute to that overactive bladder or difficulty emptying your bladder too. So I do see patients that tend to notice that they can associate their hysterectomy with their symptoms.
And here's a great question. Does my primary care or OBGYN need to refer me to a pelvic floor specialist?
That's a wonderful question. I'm so glad you asked because you know what? You don't need a referral. Anyone can make an appointment with me and to see me. And if you know you've got these issues, you can just come right to the source. I certainly do see referrals from primary care and OBGYN, and they're my partners in help treating other medical and other obstetric and gynecology conditions. But for these specific conditions, you don't need a referral. You can just come right to me.
That's nice to know. And then I know we're focusing more on bladder leakage, but there was a question about what other pelvic floor conditions do you and your team treat, and talking about pelvic organ prolapse?
Yes, you know, pelvic organ prolapse is also a very common condition, and this usually is a symptom of, and people feel, oh, my bladder's dropped, it's coming out, I'm seeing a bulge in the vagina, I feel pressure, heaviness, or something kind of pulling, worse at the end of the day. Some people see it outside of the vagina or have to lift back up on their uterus or vagina to empty their bowels or bladder. So that's certainly one that I see a lot. And definitely can take care of, you know, other kind of vaginal lesions, cysts, various conditions that affect the vagina or the bowels, accidental leakage of bowels or difficulty emptying that could be related to prolapse or other disorders. I see a lot of patients with even more complex things like fistulas or kind of holes between the bowel and the bladder, or the bladder and the vagina, or complications of surgery that they've had to the pelvis. So a variety of things.
Well, we may not need to do another webinar to talk about all those. So just if people want to see, you know, have some other areas that you would like to hear Dr. Siff talk about at another time, please put that in the comment section also. And here's a question from one of the audience is, are there any procedures or patient plans to reverse stress incontinence? Or would they need to be reversed if one were to want more children?
That's a really great question. And send in a follow-up question or chat me if I'm not addressing exactly. But I think if you're wanting to have a procedure for stress incontinence, there are really two main ones. In the office, there's that bulking procedure to the urethra, and that's kind of taking that wide open urethra to a more narrow one. That is an option that you would not really reverse necessarily. It does often tend to kind of wear off with time, actually. They're meant to be permanent, but we do see some of these things, these efficacy wear off. Slings, for example, or the other non-mesh surgeries that I mentioned, are your options to treat stress incontinence. If you've had those and you would like them taken out, typically, you know, some people have difficulty, you know, there is a small chance that a sling could move and become too tight, and then, you know, certainly you're not leaking anymore with coughing, laughing, sneezing, but now you can't empty your bladder. There are ways to remove a sling or loosen a sling, kind of revise that if that's an issue for you. And that would be a procedure in the operating room. So there are possibilities. There's no reason you would have to have that done unless you were having a problem from it. And in terms of if you wanted to have more children, we followed research of women who had sling procedures and then became pregnant and had both vaginal deliveries and C-sections. And we think it's safe to do either of those. And no one was necessarily more likely to have their stress incontinence come back in either the vaginal delivery or C-section group. And no one had major complications from that. So certainly you would be able to have children if afterwards you decided that you wanted to do that. And we do think that childbirth and pregnancy increase your risk of incontinence. So that's something to keep in the back of your head, but it's definitely not a hard and fast rule that you have to have it reversed in order to have more children.
That's great. Let's see, I'm not seeing any more. Maybe there's one or two more. I'm not seeing anything. Anyone else have any? Is there anything else that you'd like to add, Dr. Siff?
No, I just want to thank everyone for coming tonight and for asking these questions. I know it can be embarrassing, and maybe you don't feel or you're not in a good place right now to really type or to put this on a high volume, but I appreciate your attendance, and certainly give us a call, make an appointment. We can discuss in a more private setting, and we can get to the bottom of what's bothering you. And if it bothers you, like we said, you don't have to live with it. It's not just normal with age to leak or to after having babies. We can help you, especially if it bothers you.
Thank you, Dr. Siff. It was such a pleasure having you join us in this discussion. It's really nice to know that bladder leakage is not only a common problem, that we shouldn't feel embarrassed about it, but that there's so much help and treatment options that are available before it becomes a major issue. So there's the number again if you want to schedule an appointment with Dr. Siff or another pelvic health specialist, 804-628-0691. And for more information on VCU Health's urogynecology team, please visit vcuhealth.org or follow us on Facebook. Thank you so much, Dr. Siff, and thanks to all of you who joined us tonight. Enjoy the rest of your evening.
Thank you.